In this lecture, we are going to present the use of handheld ultrasound devices in the primary care setting with the focus on musculoskeletal applications. Here are some of the advantages of point-of-care ultrasound. We have the ability to do dynamic imaging, we have portability, we have an immediate result, and we also have a possibility in some cases that it may reduce the number of X-rays we perform and therefore reduce the radiation exposure. Swelling and pain in joints is a common presentation in the emergency department, which can be caused either by injury or types of arthritis. Joint effusions after injury might implicate a more severe injury to the surrounding ligaments, tendons, or an underlying fracture. Ultrasound, for example, can be used to detect joint effusion or hematoma from a fall, which may direct the doctor to have further tests performed, such as an X-ray to rule out a fracture. Here we have causes of knee pain, which include injuries, mechanical, arthritic, and excessive weight. A knee injury can affect any of the ligaments, tendons, or bursa of the knee, as well as the bones. One of the common signs of a knee injury is knee fluid. The accumulation of fluid can be an inflammatory reaction to a knee injury and can be easily detectable on ultrasound. For the POCUS examination of the knee, we will focus on the Baker cysts, the suprapatellar bursa, and the prepatellar bursa. So here are some of the bursae of the anterior knee. We will look specifically at the suprapatellar and the prepatellar bursa. Ultrasound can be helpful in determining if the swelling in the knee is an excess amount of fluid in the bursa, and even be used to guide a needle to take a sample for diagnosis by pathology. This sample not only helps reduce the pressure on the knee for the patient, but can be used for diagnostic purposes to rule out infection, for example, gout. Here on the right, we have a suprapatellar bursa with fluid. On the left here, we have the position of the transducer in the longitudinal plane that corresponds to the image on the right. This is a transverse image of the same fluid in the image prior, with the transducer now in a transverse plane and the corresponding ultrasound image here on the right. Here again is a longitudinal image of the suprapatellar bursa fluid, this time with the leg extended. So you can see here in the diagram the leg is fully extended. Here is the fluid still apparent on the right of the screen. Sometimes if there's not much fluid present, with the leg extended, you may not see any fluid at all. So it's important just to have a look in this plane. Plus, as we see on the next slide, the knee is now flexed at an angle between 45 and 90 degrees. This shows the maximum extent of the fluid in that bursal region. And here on the left, you can see the corresponding diagram of the knee flexion. Now moving on to the prepatellar bursal region. This is located between the patella and the overlying subcutaneous tissue, which we can see here on the image is the patella with the echogenic bony cortex and the posterior shadowing. And there's our skin and subcutaneous area at the front with the bursal fluid between those two layers. Over on the left here, we have the transducer position that's corresponding to the image that we have here on the right. We can use a large amount of gel as a standoff so that we don't squash any small amount of fluid seen in this bursa and seen in these images. Prepatellar bursitis is often caused by pressure from constant kneeling or a direct trauma to the knee. Infection due to a wound on the skin can also be a cause. Those with rheumatoid arthritis or gout are also more susceptible. Now moving on to the posterior knee, these are some of the causes of the posterior knee pain specifically. So we can see we have injuries, mechanical, arthritic, and excess weight. The patient may present with acute onset of pain and swelling of the posterior knee and calf, where the differential diagnosis could be a DVT or a ruptured Baker's cyst. A chronic presentation might be popliteal tightness or mass with or without pain. Baker's cysts are often symptomatic and can also be an incidental finding. They're most commonly seen in patients over 50 years of age, and it's either a collection of fluid isolated to the gastrocnemius tendon and semimembranosus tendon bursa, or commonly a fluid collection with a connection to the knee joint. The knee joint fluid squeezes through a valve-like connection into the gastrocnemius semimembranosus bursa. In a transverse plane, the ultrasound appearance of the Baker's cyst is well defined, fluid-filled collection, either anechoic or with internal low-level echoes in the case of a rupture. The fluid has a neck extending as it wraps around the medial head of the gastrocnemius muscle and appears as a crescent shape or speech bubble. We can see that here at the image on the right, this crescent-shaped fluid-filled structure. On the left, we've got our corresponding transducer position in a transverse plane that gives us this appearance here. On the next slide, we now have the transducer positioned in a longitudinal plane with the corresponding images here on the right in longitudinal of that same Baker's cyst. Other pathologies which may be mistaken for fluid in the bursa are large parameniscal cysts, popliteal cysts, or hematomas. So now we'll come over to our anatomical model of the knee and look at our transducer positions to image the knee joint and the patella bursa region for fluid. We'll use our handheld ultrasound device, which has dual probe capabilities. On one end we have our phased array and on the other end our linear transducer. We almost always use our linear transducer for all MSK applications, so that's what we're going to use now. Coming over to the anterior part of the knee, we're going to place our transducer with the notch, which is our marker end of the probe, towards the patient's head, and the non-marker side sitting up against the superior part of the patella. We're then going to slide side to side to image the suprapatellar bursal region for any fluid that we may find. Then we will rotate the transducer 90 degrees anti-clockwise so that we can image that space or potential space in a transverse plane. Rotating back to our longitudinal plane, we'll then slide onto the patella region, being careful not to put too much pressure on that and disperse the fluid, looking for any pre-patella bursa fluid in both the longitudinal and again in the transverse plane. That completes the anterior part of the knee. Now we'll have a look at our posterior part. And this is where we're going to look for any posterior knee joint fluid or our commonly seen Baker's cyst. We're going to start in a transverse plane at the knee crease and then adjust our depth, etc., before we start sliding cephalically and caudally, looking for any fluid in that potential space. In this model, our semimembranosus and our gastrocnemius tendons and muscles have been cut away, so our potential space for the fluid is in here, between the muscles that have been cut away and our joint space. Then we're also going to look in a longitudinal plane, once again, side to side across the long axis of the transducer to look for any fluid. And that concludes our anatomical positions for the transducer when looking at the knee. Now we'll begin scanning the anterior aspect of the knee, looking for fluid in the suprapatellar region, prepatellar region, by putting some gel on the knee to start with. Making sure we select our preset for our musculoskeletal setting. This will automatically also select the correct end of the transducer, which is the linear transducer side. Spreading the jelly down, we're going to ask the patient to bend their knee slightly. This will help to bring any fluid that possibly is in the suprapatellar region out into the bursa. I'm going to start with the marker pointing towards the patient's head, which is that notch on the transducer side, in a longitudinal plane placed at the superior border of the patella. The patella is our bony landmark, which we can see here on the right side of the image. And I'm going to slowly start to slide cephalically to bring the femoral condyle here into the image. I can adjust the depth a little bit shallower and also adjust the gain. So here I have my bony landmarks, also now with the quadriceps tendon inserting onto the patella. So our potential space for fluid in the suprapatellar region is between the bone and the quadriceps tendon. I'm now going to slide the transducer from side to side in this region, looking for any potential fluid in the knee. And here you can see this anechoic region here is a small amount of fluid in that suprapatellar region. Once we've found the fluid, we need to confirm in transverse plane that it really is fluid and it's not an artifact. So I'm going to rotate the transducer 90 degrees. And yes, directly over where I was, there is fluid there, that anechoic area. We can also scan up and down the knee, just making sure there's no further fluid. In this region, we can get this artifact called anisotropy, where we can make the tendon look like anechoic fluid. So in this instance, I'm going to make the tendon look anechoic, which you can see here above the suprapatellar bursal fluid. To make sure it's not an artifact, we need to tilt the transducer to bring the scan beam at 90 degrees to the tendon, and then we can see the fibrillar pattern there of the echogenic tendon. Again, if I tilt the other way, we can make it look black again. So just be aware of that in any sort of musculoskeletal imaging. I can demonstrate this anisotropy also in the longitudinal plane. So I'm just going to rotate the transducer back around. Here I can see the beautiful fibrillar pattern of the tendon in the quadriceps tendon here is the echogenic fibrillar pattern because I'm 90 degrees to those tendon fibers. If I tilt the transducer slightly this way, you can see now that the tendon looks quite anechoic. So we're not able to visualize it very well. And again, it's just the artifact. It's not because the tendon has pathology. So we're going to tilt back this way and we can see it nicely. We will also examine the knee with the leg completely extended. If there's a significant amount of fluid, we will still see it with the leg extended. If there's only a tiny amount of fluid, it won't be as visible. So I'm going to ask my patient just to slowly straighten their leg down until it's completely extended. And you can see here in that dynamic study that that fluid has completely disappeared now. Again, in a patient with a significant amount of fluid, there will be still visible fluid there. And again, I'm just going to slide the transducer side to side and we can see the fluid's completely disappeared. You'll also notice now the quadriceps tendon has these dark or anechoic areas coming down. That's because we've got anisotropy occurring due to the fact the tendon's not on their full stretch. Now we're going to continue on to our prepatellar bursal region. The best thing to do here is to place a large amount of gel on the kneecap to use it as a standoff. So we'll just do that now. What this does is it gives us a nice standoff between the skin and the transducer, but allows the sound still to travel through. Because often the prepatellar bursa region only has a very small amount of fluid, and with any probe pressure at all, even very gentle pressure, it may dissipate the fluid and you don't visualize it. So as you can see, the gel acts as a nice standoff for us to examine that prepatellar region. Scanning from side to side. All we can see is the patella at the back of the image, which is our bony landmark. We can see the skin, and between that we've got our connective tissue and our fat pad and our muscle. No fluid present. Again, we can turn the transducer 90 degrees into transverse position and scan through as well. No fluid present. So that concludes the anterior part of our musculoskeletal imaging of the knee, looking for any fluid. For the remaining knee musculoskeletal scanning, we're going to have a look at the popliteal fossa to see if there's any Baker's cyst, as well as at the posterior knee joint for any fluid. Place some gel on the knee. Place our transducer in a transverse plane, again with the marker pointing towards me, at the knee crease. We're going to slide our transducer slightly medial to identify the femoral condyle again as our bony landmark, and then just superior and in the middle of the image there now we've got the gastrocnemius muscle or tendon. As we slide up, we're looking for fluid to pool around that edge of that gastrocnemius muscle. And now I'm going to slide down towards the calf, again looking for fluid in that gastrocnemius muscle area. Back up again. Here we can see a tiny slither of fluid just underneath that gastrocnemius muscle. Is it an artifact, anisotropy, or is it real? So we're going to rotate into a longitudinal plane and sliding through that area. And there's possibly a tiny amount of fluid present in this region. It may not be causing the patient any symptoms, but it's something to be aware of. Now I'm going to slide more into the mid part of the knee joint. Again, I've got the two femoral condyles on each side of the image, and I'm just looking for any fluid in that knee joint in the mid portion. Sliding up and down. And again, as I'm sliding through, I notice a small hypoechoic area deep in the image there in the middle, which is possibly a small amount of fluid. And that's probably the connection with the small Baker's cyst that we've seen medially. I'm rotating the transducer 90 degrees into a longitudinal plane, and there we can see that same fluid in the longitudinal plane, just sweeping through there. And we've proven that it's a real structure. Sliding over more laterally, and again just sliding up and down. So we've now completed our musculoskeletal knee ultrasound examination. So to summarise, this lecture demonstrated the use of a state-of-the-art handheld ultrasound device in the primary care setting with the focus on shoulder and knee. We discussed anatomical planes for transducer position with corresponding ultrasound images. We have shown some examples of common pathologies you may find and emphasised the learning experience with live scanning demonstrations.